Hello. I think we are going to a very difficult topic, and nobody wants to treat MDR patients. So always physicians hate treating these patients somehow. So we'll be very pleased to listen what are new concepts in this MDR.
Good afternoon. Welcome. Thank you for calling me for a chair. I welcome Dr. Preetam Dhande for his today's session on MDR tuberculosis, a very important and emerging drug-resistant tuberculosis in India, for his talk.
Thank you, sir. After this good burnout, let's start with something very serious. So we have the changing paradigms in the management of tuberculosis and also in the MDR. So the India TB goal, according to WHO, it has intended to end TB by 2030, while India has set up a target of 2025. So now closing the gaps, I think advances in the TB are coming out with Terramdus and the HIV, which was epidemic in 20 years back, and then we had COVID, which was pandemic, and the TB was always remained the epidemic. And now, since 10 years, it is MDR-TB. So the government has been very actively involved with this, with the involvement of our Prime Minister. Though what is anti-EM? It is like having 44 new TB cases or total of 65 cases per lakh of population. So there is also the other niche, like the COVID patient used to be targeted, tracked, and same the niche ID has been doing. And another the thing is been added to the program is the incentive the patient are getting for their treatment completion, for their nutritional allowance. Since this, there has been very good kind of result coming up for this program. What are the updates we are having? Not going into the pathophysiology and the introductory part, the things in the TB advances in the world up to such extent that we have new guidelines every 6 months. So we need to keep ourselves updated. The updates are in the diagnostic, then second is the sample collection and the treatment updates, and recently we are thinking of latent TB treatments. The diagnostics, as we all are aware about the gene expert, which is widely used in India. Another thing is the TrueNut, which is an India-made product. It is having the processing, like a little bit more processing to put in this machine. Now the gene expert Ultra is there, which the maker has came up with, which can detect 16 colony forming unit per ml. There is also been a line probe assay already in the program. Then newer thing is the gene expert XDR panel. The mutation associated with the resistance with INH fluoroquinolones and second line injectables like amikacin, kanamycin and capreomycin has been easy to detect with this test. So going with the case, a 25-year male having a fever, vomiting and 2 episodes of convulsion. The MRI brain was suggestive of hydrocephalus with leptomeningeal enhancement with multiple tuberculomas. As per the old guideline, we must have we planned for the gene expert, or the treatment was planned according to 2015 guidelines. But what we did, we evaluated the patient. We did gene expert for CSF, which came resistance for rifampicin. Then we planned for CSF XDR panel where the INH resistance was detected. So we were not able to use, we can't use the INH in this kind of treatment. So ethionamide was another option, which has excellent penetration in the CNS. So regime was directed accordingly, and we were able to start the treatment on the same day we get the report. Usually it used to take a week to get the sensitivity and all. The treatment used to delay in this kind of patients. Another newer thing is now the genetic sequencing. We already started the whole genome sequencing, exome sequencing in genetic disorders. Similarly, in the mycobacterium, we go for the pyrosequencing. Which is the best method to diagnose the latent TB? Is it Montux or chest X-ray or interferon gamma release assay or CTB? Yeah, this is actually the correct answer. Interferon gamma is the test to detect or diagnose the latent TB. Then interferon gamma release assay. Earlier we used to use the Montux test. Now it has been replaced with IGRA, which detect the hypersensitivity towards the specific antigens of the microtuberculosis and quantitatively measure it. So accordingly, we can decide is it a active case or a latent TB case. The program says no to the Montux because of this. The CTB is the newer test which has been under trial with, in India with ICMR. The next gen skin test to detect the TB. It is based on the IGRA antigens like ESAT and CFP10 antigens. So this is under going to replace the Montux. So it is going to new test which can be replacing the Montux. Another thing is the AI-based chest X-ray reporting, which is under trial, and soon it will be getting into the program where the patient will be able to access and be reported according to in the periphery. Then we go for what is happening in the updates regarding the sample collection. Sputum in the suspected and gastric lavage and aspirate in the children, BAL, CSF, ascites, pleural fluids depending upon the part of body which was involved, the sample is been taken. The newer thing is the stool, still not in the program, but it has higher yield than the gastric lavage. So this will be getting into the program. In this case, we can see the 10-year female which presented to us with abdominal pain, distension for 2 days and vomiting for 2 days and fever since 1 month. She was diagnosed with sealed intestinal perforation with a sealed peritonitis, with omental caking and the necrotizing mesenteric lymph node, and with left lower lobe disseminated TB. The gastric lavage came negative, planned for the surgical exploration. But the thing is, we did the stool gene expert ultra, which came rifampicin resistant, and rifampicin sensitive, and we were able to manage this patient without any surgical exploration. The other tests which are in pipeline, the nasopharyngeal aspirate, the face mask sampling. We are not think of nasopharyngeal aspirate because it is difficult and the yield is least among the all sample. Newer is the face mask sampling. In this, the gelatin-based face mask being used, and the suspected are being suspect will breathe into the mask, and this gelatin will be processed for the PCR. The following diagnostic the following diagnostic of the pulmonary TB, gene expert shows rifampicin resistance. What we do next in the management? Check for the resistance for INH, ethambutol paracetamide, or check for the resistance for kanamycin, or check for the both of the lines of treatments. The answer is that we check the resistance to first line, second line drugs. So many of us gave the answer very correctly. The treatment updates are the treatment regimes and newer drugs. As we look upon the updates, the treatment is newer drugs and newer treatment regimes. Say the example, DSTB usually being treated in 2 months of intensive phase, consists of HRE's head and 4 months of treatment of HRE. Presently, this is the standard. This is a very complicated chart which has been given in the guideline. The flow charts tells about the sample testing protocols deciding the regime. And this is the rifampicin sensitive treatment, which is very standardized and been followed. Only the changes which has happened is that the change in the drug dose of INH, which was earlier 5 milligram, now it is 10, and of rifampicin, which was 10, now it is 15. These are the groups of different MDR drugs. And now it is, if you come to the drug resistance TB, the grouping of the drugs keeps on changing as the data comes. Earlier, the delamanide was in the group A, now it is in the group C. 5 drugs regimes need to be formed for the treatment of DRTB, which includes all the medicines of group A, any of the medicines of group B, and if in the combination, if it is not working, then we can add the group C drugs also. What are the new treatment regime we are not following for the MDR-TB? The bedaquiline-based shorter regime, the recently studied regime which is widely used in India to treat and which has demonstrated about 82% of the success rate. It has 2 phases of intensive and the continuation phase. And bedaquiline, which was added and has to be continued for 6 months. Any change or combination composition of this strain need to shift to the longer regime. 4 weeks back, we got this regime, and the Ministry of Health and Welfare has also recommended to use. So this is going to come into the new guidelines for the rifampicin resistance and fluoroquinolones resistant TB. The WHO has done, now it's our chance to move with these guidelines. The BPAL and regime, which is already been under planning, the already existing 9 months of regime of MDR for rifampicin TB without fluoroquinolone resistance, and longer regime. All these regimes are oral treatments, no injectable being added to this. So more focus on the domiciliary kind of treatment being recommended in this. In this, we can see the many drugs are in the developmental phase, and also the phase 3 trial for the biologics like immunoxil are also undergoing simultaneously. So there is a lot to come for the TB treatment. Then another case with the 81-year male presented to the hospital with a chronic cough since 2 months, and the patient was reviewed outside by the physician and CT was done. The CT was suggestive of the right upper lobe cavitary consolidation and likely suggestive of the tubercular etiology. The patient was started on empirical AKT. But what we did, the patient was having progressive and chronic cough, and no result was there after starting AKT. We did a check bronchoscopy to confirm the TB, DRTB, and to rule out malignancy. The answer came to be like it was a foreign body which was there in with the patient. Like Supari, it was there since 2 months. He has aspirated, which he forgot to spit out during sleep. So all it seems to be TB is not always a TB. So we should avoid starting empirical AKT TB treatments in such kind of patients. To achieve the goal of NTEP, the most needed intervention is to target the latent TB. Different regimes have been recommended under NTEP. Just 2 days back, there has been a government of Maharashtra has issued a letter to IMA, IAP to implement this into their implement this treatment to patients with having the household contact with the pulmonary TB. So these are the regime. The regime includes the 6 months of isoniazid monotherapy and 3 months of weekly rifampicin and isoniazid drug. Approximately 12 dose treatment is there, very short treatment. So we should always, we should now comply with this new implementation. The conclusion is, not able to access that. Yeah. The conclusion is like it is now time to see the latent TB first and treat the patient. we should avoid the empirical AKT treatment to the patient, and also the upcoming diagnostic test like gene expert XDR panels are upcoming. So we should be seeing many more things changing and likely to achieve the TB elimination by 2025 if everything goes with this plan. Thank you.
The session is open for questions.
I think all these drugs, they are available on government hospital
Yeah,
basis, or patient has to purchase, and
No,
purchase,
sir.
what is the cost?
Yeah. Sir, it is now in Mumbai, it is been given to the like practicing private practitioner also.
Particularly about bedaquiline.
Bedaquiline also it is been
Is it
there.
available in Nagpur?
No, it is not
We have to
available.
take permission from
It is
JJ.
available.
Yes.
It is
It is
available.
available for the means some dedicated center for DRTB centers. There it is available, and we are being using it.
So, no, what is the prerequisite for procuring bedaquiline or to put the patient on bedaquiline regimen?
The prerequisites are, sir, there are some inclusion and exclusion criteria to
Yeah.
include for the bedaquiline actually. It is not so easy to start a bedaquiline in the patient. Many pre-treatment evaluation need to be done for this patient. Seeing their because the bedaquiline itself a cardiotoxic drug. So we need to rule out the electrolyte balance, imbalance, everything. And before the starting also, there are like, as it is a very costly drug and there can be misuse of that drug also can be there. So,
Nowadays, in our program, whatever the government of India has given to us, bedaquiline is given to all patients. There are two regimes which are followed in MDR. One is the all shorter and one is longer. All patients have to be started on all shorter unless and until contraindicated for other drugs, and to be started on all longer. All shorter regime consists of bedaquiline, and bedaquiline is freely available with the government. If you are working as a private practitioner, you get your patient registered under the NTEP program, and then you can procure the drugs from the government sector. It is given free of charge, but before that you have to do a pre-treatment evaluation. And now we have come up with the newer regime, that is a BPAL regime, which he has told in it. It is a combination of bedaquiline, pretonomide, linezolid, and moxifloxacin. The only 4 drugs are to be given for 6 months, which has been approved by the WHO in 2022, and now it's coming to our national health program. And during the treatment, if the patient is coming resistant to moxifloxacin, you can continue for only 3 drugs. And instead of some persons, instead of using moxifloxacin, are using colchicine, but it is not recommended. Only BPAL with M is recommended for treatment of MDR tuberculosis. That would then if the patient is not fit for BPAL, if you don't have that amount of money, or if you don't have that regime available with you, then you can directly start him with the all shorter regime, which also consists of bedaquiline. And if it is resistant to more than second line fluoroquinolones, or more than the drugs which are included in the all shorter regime, then as is shown in the chart ABC, you make a regime from the ABC group, and the medicines which you choose is starting from the group A, group B, and group C, because the efficacy and is more among the drugs which are of group A. Depending upon your resistant pattern which you receive and sensitivity pattern, you can make your regime. And for the all shorter, it is 9 to 11 months regime, and for longer it is a 18 months regime. If I am not wrong, Preetam, you can correct me.
We need to add one injectable. In India, still we are following that regime. Is that correct? What are you following?
Sir, now the things are like all
Vicacin
treatments.
or capreomycin or
Yeah,
streptomycin. Any of the one injectable should be there.
Now,
We are now using only oral drugs. Injectables are out of the regime. Even the ABC group doesn't consist of injectable. It is very rarely used. All oral regime. Very rarely we use injectable. In the National Tuberculosis Elimination Program, it is clearly given in PMDT, programmatic regime, which is followed for MDR tuberculosis. Also, it is clearly given that no injectables is to be given. Even in CNS patient, he has given us a choice for medicine in CNS patients.
CNS patient, epithelial. So just to add one point, we can add a injectable in case we do a DST culture report, and if it is benefiting the patient, the regime can be like add on or delayed depending upon the different patient. It is more as a patient-centric treatment can be done if needed.
Yeah, exactly. I think that's all about this session. Thank you.